Greetings, friends and colleagues. I'd like to welcome you to CI 2021 and thank you for taking time to join us today for our panel on social justice and hearing healthcare addressing equity in cochlear implantation. Sorry for the late start, but I think we've got a very exciting and interesting panel for you today. These are my disclosures. Our individual speakers will share their own disclosures during their portion of the presentation. Current events have drawn our attention to and amplified long-standing inequities in our world. We are facing sobering realities of the global strain on healthcare capacity, as well as the indwelling systemic racism in society, health, and healthcare. We are compelled to take a deep dive into considering social justice and health equity in our lives, our practices, and our research. We need to take a serious look into these topics to make better choices, to say better things, and to be better people. Social justice can be defined as the distribution of wealth, opportunities, and privileges in society. A closely connected term, equity, involves ensuring opportunities for everyone to attain their highest level of health. This will require us to remove obstacles to health such as poverty, discrimination, and their consequences such as powerlessness and the lack of access to quality education. The American Public Health Association has summarized and strategized an action plan to address this topic in a document entitled Creating the Healthiest Nation, Advancing Health Equity. We will refer to some of these concepts and principles during this panel. From that action statement and this document from the American Public Health Association, there are 6 principles for advancing health equity that they have outlined. Number 1, be explicit about naming the disparity and naming the inequity. Number 2, identify and effectively address racism and racial implicit bias. Number 3, adopt a health in all policies approach. Number 4, create an internal organization-wide culture of equity. Number 5, respect and involve communities in health equity initiatives. And 6, measure and evaluate progress in reducing health disparities. So we're left with the question, what does social justice and health equity have to do with cochlear implants? Certainly we can't cover this topic in a comprehensive fashion today, but I'm joined today by 4 of my friends and colleagues, Dr. Jacob Hunter, Sheree Sims, Dr. Susan Emmett, and Dr. Carrie Nieman, who I will introduce individually, and we will discuss some of these aspects of social justice and health equity. Dr. Hunter is an assistant professor in the Division of Otology, Neurotology, and Skull-Base Surgery in the Department of Otolaryngology at the University of Texas Southwestern Medical Center. And he's going to discuss initially the disparities that exist within our field, to be explicit about naming the disparities in cochlear implantation. Ms. Sheree Sims is an otology and neurotology and cochlear implant coordinator at the University of Cincinnati. And she is going to describe a very personal firsthand experience with dealing with disparities and dealing with inequities, and her role as a coordinator to try to reach out to a local community to address a great divide. Dr. Susan Emmett is an associate professor of head and neck surgery and communication sciences and an associate professor of research in global health at Duke University. And Susan's going to describe how research can be involved in addressing connections and addressing communication with vulnerable people groups and vulnerable communities, and being able to bring in stakeholders and community members to participate in coming up with solutions to address inequities in care. Dr. Carrie Nieman is an assistant professor in the Division of Otology, Neurotology, and Skull-Base Surgery in the Department of Otolaryngology at Johns Hopkins University. And Dr. Nieman is going to share a little bit about a 30,000-foot view and a broader view of social epidemiology and how this relates to disparities and how we might be able to have better conversations about social justice and health equity in cochlear implantation. With that, I'll let Dr. Hunter take the lead to describe hearing health disparities.
Thank you, Matt. Thank you, Dr. Bush. I'm honored to be invited to be on this panel with my esteemed colleagues. I've actually referenced all their papers in the paper I'm going to talk about. And as Matt pointed out, I think my role on this panel is to kind of set the table, to not only to be explicit in what we found at UT Southwestern, but I think it also provides at least that sixth key principle as well in that Public Health Association article, that we're able to measure what change we can make, since we'll have a starting point and then being able to compare it to what implementation we might be able to provide moving forward. So these are my disclosures. So as I mentioned, my role on this panel, I think, is to set the table. I think everyone listening to this talk right now is aware of the low utilization rates of cochlear implantation. And I think there's many bottlenecks along that line. And so we started to look at our internal database, really. We actually put together our internal database just to kind of start from scratch, and literally putting it together without even looking at the data from a distant perspective. There was clear differences in what we saw. I mean, we found that we are evaluating a large percentage of white patients, and just looking at that, we just did not feel that reflected our community. And so we kind of wanted to know why. And I don't know if I can truly answer that today, but it allowed us to be a little more introspective and to try to look at what we could do differently moving forward. So we actually then decided to look at those patients who came in for a cochlear implant evaluation, looked at a number of demographic variables, and then looked at whether those patients pursued surgery, among some other issues. And I'll present data focused mainly on race, but there are actually other factors that play a role. And so this was published actually, I believe 2 years ago, maybe a year ago. I mean, this we put together 2 or 3 years ago, and really could not have been done without the first two authors, Dr. Anthony Tolosano, who was our neurotology fellow at the time, who's now currently a staff neurotologist at Walter Reed, a National Military Medical Center in Bethesda, Maryland, and then Natalie Schauwecker, who was a UT Southwestern medical student at the time, but is now a soon-to-be otolaryngology PGY2 resident at Vanderbilt University in Nashville. And in brief, and I'll go through it in a little more detail, what we found when we compared in reference to white patients, that non-white patients were significantly more likely to qualify for an implant when they came in for an evaluation. And then when we looked at those patients pursued a surgery, we found non-white patients were significantly less likely to pursue surgery than those white patients. So we actually looked at our center over a 10-year period between 2009 and 2018. And we looked at all adult patients who came in for a cochlear implant evaluation. It amounted to 832 evaluations. And we deemed those patients who were with private insurance with sentence testing, who scored less than or equal to 60% in the best aided condition as patients who qualified for an implant, and those patients with government insurance less than or equal to 40% with the same sentence testing as those patients who are deemed cochlear implantation candidates. We found overall, it was, I think, if I remember correctly, the mean age was about 64 years of age. 55% of the patients were male. But as it turns out, 88.1% of patients who came in for an evaluation self-identified as white, and 91.3% self-identified as non-Hispanic Latino. The remaining percentages, 6.2% were African-American, 2.6% were Asian, and the remaining 2.6% were considered others. So overall, kind of what I kind of tell everybody is roughly about every patient that comes in, so 4 patients that come in, 3 qualify for an implant, and 2 of those 3 pursue surgery. But with this table up here, this is looking at categorical variables. And on the left, it was looking at the qualification information. And so we found that non-white patients who came in qualified for an implant over 90% of the time compared to white patients, which is about 77%. So if we look at that a little differently, you could argue that non-white patients are presenting to our clinic further along in their hearing loss journey. Like perhaps they could have come in earlier and maybe we would be telling them they don't qualify at that time. So we feel that they're late to the game perhaps in discussing the cochlear implant. And again, I don't mean to speak to what conversations they had about an implant before. I mean, obviously we're discussing concerns or barriers to even surgery. So maybe they're even hesitant to get to our center because they're like, listen, we're not going to do surgery. But clearly that there was a significant difference between those. And then when we looked at surgery, there was a clear negative, significant negative association between those patients who are a non-white as reference to white patients in pursuit of surgery. And I don't want to steal Sheree's thunder, but she points out, and I think we'll discuss some reasons why that might be the case. Obviously, we looked at a number of variables, and so we ended up looking at we created logistic regression models. And so from a qualification perspective, when we controlled for these additional variables, it turns out the only independent predictor for qualification was age. Specifically, it turns out that every year younger, a patient was 2.5%, had a 2.5% increased chance or likelihood of qualify for an implant. But when we looked at surgery and multivariable analysis, we actually found that the negative association strengthened controlling for other variables. So the odds ratio was 0.47 for non-white patients compared to white patients. And this is not unique to cochlear implantation. There was a recent review that looked at post-mastectomy breast reconstruction, and they found that African-American women were half as likely to pursue surgery as compared to non-African-American women. So clearly, and I guess I'm kind of stealing Sheree's thunder, there's a level of perhaps distrust. I mean, clearly I and our team, our multidisciplinary team, is not doing perhaps our job as best as maybe we could to be able to say, like, listen, this can be a benefit from you. And there's clearly barriers that are preventing people from pursuing surgery. And while that's on me and our team, obviously there's other potential barriers. I mean, as I pointed out, there are patients that are perhaps coming in further along in their hearing loss journey that they could have come in earlier. So, and I'll get to that shortly. The other thing that this provided as perspective, and this goes back to the original question, was like, wait a minute, do we truly represent our community? And so this is a very simple bar graph. I'm not the biggest fan of bar graphs, but I think it really accentuates the difference what our center demonstrates in compared to our metropolitan region and our state. So the first bar graph on the left is white patients, the middle is non-Hispanic patients, and the one on the right are those patients with English proficiency. The smallest blue bar on the left is those patients in Texas, the middle's in DFW, and then the largest is our evaluations in our center. So again, looking at white patients, we clearly do not represent our community, our DFW metropolitan area, which is our large referral base. We're, as I said, we're not representing our community. We need to do a better job of getting out there. And I think Dr. Nieman's going to discuss one of the things that they're doing about this in Baltimore. And this just highlights the inequalities that our center has with our region. I also don't want to state, as I said, that it's only a surgical issue. I mean, there are some limitations with what I'm about to state, but there was an interesting article that came out, I guess, in 2015 from a health geographer, Dr. Ariana Planey from the University of Illinois, Urbana. And so what she looked at was speech language pathologists hearing data set numbers in 2015 and accounted for, I think, 13,500 audiologists and looked at it on a county level. And so what she found is some counties ranged from 0 to 197 audiologists per county, with a mean of about 4 and a median of about 2. But she also identified that less than half of counties in the US actually have an audiologist. So perhaps going back to the fact that we're having non-white patients come in later into our clinic, perhaps they're not having their needs met from maybe, I don't want to say they're the only gatekeepers, but even getting their hearing checked, being able to understand, do they have hearing loss, being able to understand, do they need a hearing aid? to be able to understand they are not doing well with a hearing aid, and that maybe they're a cochlear implantation candidate. So the figure on the left is just the count of audiologists per county. And then when you control for population, you can clearly see there's a discrepancy based on the rate of audiologists per population throughout every single county in the country. Interesting, there's like, I think 1,350 counties in the entire US. The one big limitation with this study, though, is that she did not account for racial disparities, did not control for those differences based on these counties. But again, just food for thought to question, I mean, there's multiple barriers here. I mean, perhaps, again, from an audiologist perspective, we're not getting them into their evaluation appropriately or quick or early enough that maybe more patients would qualify. We're not the only study, though, that has identified this discrepancy. Dr. Jordan Holder and Dr. Renee Gifford at Vanderbilt a few years ago looked at their evaluations, cochlear implant evaluations in adults between 2013 and 2015, slightly smaller number, but they too emphasized that their evaluees did not represent Nashville, did not represent Tennessee. They had a similar number of white patients that came to their clinic as compared to ours, albeit their metropolitan area is a slightly more has more white patients than our DFW area, noting it was 78.7%. And so bringing this back full circle, bringing it back to what Matt pointed out with that article, is that this allows us to be explicit. This allows us to measure and evaluate our progress to understand where we have been and with the changes we're hoping to implement where we will be. I think this also provides the avenue for everyone listening to this talk to be able to look at your own center, to be able to say, like, do you represent your community? Do you represent who are best served by these by your services? I feel internally, and I feel comfortable saying that at UT Southwestern we don't, and I would venture a guess that most centers don't. But in the end, as I said, I mean, compared to white patients, non-white patients are half as likely to pursue surgery for a cochlear implantation. And I need to do a better job trying to, one, identify what those issues I can address to help those patients pursue, and again, helping more patients reach their hearing potential. I mean, increase that utilization rate from cochlear implants. So again, I'd like to thank Matt for the invitation to be on this panel. I'm extremely looking forward to hearing my co-panelists talk about kind of the next steps from what we set out here to talk about. So thank you.
Hello, my name is Sheree Sims, and I'm the hearing implant coordinator at the University of Cincinnati Department of Otolaryngology. Our leadership involves ENT surgeons, Dr. Miles Penzak, Dr. Ravi Sami, and Dr. Joseph Breen. Under their leadership and with their support, I was able to assist in running an effective, organized CI program that encompasses patient plan of care assessments, educational training, outreach, and research efforts. And I'm going to discuss with you how, with the help of my CI team, I was able to start working. I was able to discuss with you, start working on disparities with cochlear implants for African Americans. Excuse me. The most compelling evidence that was observed at our clinic is the lack of African American minority involvement with cochlear implants. This has sparked a deep concern, and I wanted to research the reasons behind it. Our team created a pilot study aimed to identify the socioeconomic and cultural barriers that prevented our African American cochlear implant candidates from seeking help for their hearing loss. And what I had discovered is that African Americans were making efforts to get hearing screenings, but if they were tested and approved to be a cochlear implant candidate, they had either refused or just became no longer interested, no matter the severity of their hearing loss. Therefore, my need to determine what could be done to bring cochlear implant awareness heightened as I searched for the cause and sought for a solution. Our clinic is located in a centralized area in Hamilton County with a demographical race population of 65% white, 26% Black, 3% Asian, 3% Hispanic, and 3% other. And knowing this, I was shocked and concerned that only 10% of our CI patients are African American and 1% are other. This is very alarming considering the fact that our clinic is surrounded by heavily populated minority communities. The challenges for African Americans in hearing loss. African Americans face several challenges when trying to combat their hearing loss. Mistrust in healthcare, social injustice and medical racism with African Americans and healthcare professionals has negatively impacted the Black community for decades. While much has been positively changed, the medical community still has a long way to go. And without going into further details, the COVID-19 pandemic is a good example of the mistrust with Blacks in the medical community. Not only are Blacks paranoid and fearful about taking an unknown vaccination as they see it could potentially kill them, but there have been ongoing national news reports discussing the fact that not enough COVID-19 vaccinations are available for Black people. COVID-19 exposed a lot of racial healthcare inequalities in America. And sadly for African Americans, that is nothing new. Lack of support, information given is just not enough for some to make a decision. And one reason is because hearing loss is just not discussed in the Black community due to the lack of community outreach efforts. Lack of representation, and depending on the situation, and especially as it relates to healthcare, having an African American minority representation involved with the organization is important. And stigma. For the Black community, generally speaking, having a type of healthcare issue is a stigma, and it can be viewed as embarrassing and it can feel shameful. Illnesses or defects, for that matter, shows their vulnerabilities. And having a hearing implant device visibly attached to their head may certainly put a Black person that is suffering from hearing loss in an uncomfortable position. And then financial concerns. The moment our patients are told that getting a hearing implant involves surgery, for many, they think that's a huge bill. So one of the benefits of my role was being a one-stop shop of resources. So instead of having the patient jump through all of these hoops to get answers, they can come to me and I can be that support and advocate for things that they need. So as you see, we have some work to do. Past unethical medical practices have left a terrible scar on the African American community and to this present day, and there's work to be done with closing the healthcare gap. I want to tell you a story about one of our patients, and just for privacy, I'm going to call him CW. He was one of the participants of the study. He came in, or actually I called him. There was a questionnaire that we had established for the study, just trying to get a better understanding of why our African Americans did not or refused to get a cochlear implant. So when I called him, I had to speak with his neighbor because he had severe hearing loss and could not communicate over the phone. So CW said that he came into our clinic probably 3 years ago prior to me calling him. He was deemed a candidate for a cochlear implant. He was still kind of fearful of the surgery, but he wanted to hear more about it because he felt like he just didn't have any more options out there. They ran his insurance through and it was denied. And he was told that his insurance or his surgery along with the cochlear implant would cost about $80,000, so he refused. So as I'm talking to him, he's telling me how he's depressed and he just doesn't know what he's gonna do. And the neighbor was saying that she's getting ready to move. And then once she moves, he won't have anyone to help him with his affairs and, because she's his source of communication. So I'm talking to him and I said, CW, could you allow us the opportunity to test you again? And we can go from there. He was very hesitant because he felt like he just did not get the services and the support that he needed. And also he was just kind of like slammed with this, hey, this is the bill. or this is your out of pocket of what you'll have to pay. So anyway, long story short, he agreed to do it. He came back in. He was still deemed a candidate for a cochlear implant. He was kind of hesitant about the surgery, but after some talking and him attending our support group, he ended up getting the surgery. And I didn't hear from him for 3 years. After that, he ended up calling me back for some follow-up. And he said, hey, Sheree, I'm in the area. I wanted to know if I can get my cochlear implant looked at. And I was like, hey, you got it. And he said, yeah. And he said, I moved to Florida. I got me a new girlfriend. I got my life back. Thank you so much. And that's all I needed, was someone to just walk me through the steps. So this is just one example of just, the having that trust, that support, that representation, and just to know that things will be okay. It mattered so much to him. So who are the leadership drivers? I can't emphasize enough that there needs to be a team of leadership drivers providing a continuation of awareness and community outreach efforts. Some of my role is to reach out to our hearing loss patients to help them navigate their healthcare needs in terms of providing financial questions, getting insurance approvals, troubleshooting insurance denials, assisting with financial payments, and just being an overall liaison between the patient, the physician, and the audiologist. By being in this role, it has helped me to identify our minority patients who may need some extra assistance. And then physician leadership, healthcare officials can't have a discussion of improving the disparities with African Americans and cochlear implants without discussing the driving force that could bring about change, and that is the physician. The physician knows firsthand which patients appear to be suffering as it relates to utilizing something that will undoubtedly improve their life. It compels most physicians to establish leadership roles in making a difference for their patients' well-being. Physicians are the champions of the community, and by rallying behind these communities, we're closing the healthcare gap and getting their institutional administrators to understanding the healthcare needs of their minority patients. Audiologists, our audiologists who specialize in cochlear implants are Dr. Lisa Winstrup and Dr. Teresa Hammer. And with their expertise, we were able to perform an array of hearing loss testings and consultations. They also have helped to identify challenges with our hearing loss minority communities. And with their support, I was able to collect demographical data that assisted with our study. And in healthcare collaborations, there are a few hearing loss organizations in the surrounding area that have collaborated with our clinic to reassure that hearing loss communities are assisted in the best way possible. So bottom line, I needed my team to see the vision, and they jumped to service. They were willing and ready to do the deep work. And I think that's important for any organization that is trying to do community outreach. It's all about listening, recognizing, understanding, and wanting to do something to help bring about change. Cochlear implant support groups. So cochlear implant support groups work. First and foremost, most patients will need to learn to be their own advocate when coordinating a plan of care, but by having that extra cushion of a support group can be a more intimate and safe environment for patients to express their concerns. Non-healthcare professionals, during RCI support group meetings, a number of things are discussed, like CI device updates, troubleshooting device issue challenges. What were their experience in coming to our clinic? How were they treated? Things like that are discussed. Support to one another. Black folks need to know that they're not alone and that there are people just like them that have experienced the same thing, and they can support each other. CI support groups are serving the hearing loss community. As a matter of fact, UC Health is one of the largest CI support groups nationally. African American hearing loss and awareness. It needs to be discussed on the national platform. More careful observations as to how to effectively bring hearing loss awareness into minority communities will need to continue. But at least there's enough data and facts to show that utilization of cochlear implants is needed. Again, this will start with healthcare institutions supporting physicians, other healthcare providers, and cochlear recipients with bringing this awareness. It can't be like one or two people pushing through barriers for change, but It has to be leaders that are in positions that have the manpower to bring about policy reform and organizational modifications. A need for closing the healthcare gap. My hope is that this study is seen by medical professionals and administrators who are bothered by the misrepresentation of the lack of minority hearing implants and bring about awareness to healthcare communities. I would like my findings to open the door for Hispanics, Asians, and any other minority groups out there to have the opportunity to be involved with improving their quality of life by getting able to be able to hear again. And getting the healthcare administration to understanding the needs of African American minority communities. It can be challenging trying to convince administrators to focus their attention on things that they can't see or hear as much. However, data and performance measures are great tools to catch the attention of those that can help make about change. And I just want to give a special thanks to Dr. Matthew Bush and everyone on the panel, my new friends, Dr. Ravi Sami, Dr. Joseph Breen, Dr. Vals Pensack, Lisa Winstrup, Dr. Lisa Winstrup, and Dr. Teresa Hammer, Adele Rowan, and the ACIA. Thank you for allowing me this opportunity to present to you all. And here is our cochlear implant team here. And they're all in front of you, see. And then lastly, I just want to leave you with this quote by James Baldwin. Not everything that is faced can be changed, but nothing can be changed until it's faced. Thank you.
Good morning, everyone. My name is Susan Emmett. I'm an otologist at Duke University in North Carolina, and I'm really honored to be here with you today. As hearing researchers, we have a profound opportunity to change the landscape of hearing loss disparities through the research methods we employ. Over the next few minutes, I'm going to share several strategies that can be used across hearing healthcare research, including cochlear implant research, to empower and engage with underserved and minority communities. These methods have the same ripple power as this little pebble thrown into a calm Bering Sea one evening in rural Alaska. This has the power to really change the landscape of disparities. And I'll be sharing stories directly from the work that we have ongoing in rural Alaska. There's a tremendous amount of childhood hearing loss in rural Alaska. Historical data suggests that prevalence of hearing loss is anywhere from 6 to 9 times higher than that in the general US population. And the vast majority of this is mediated by infection. There are tremendous barriers to care in the state. And the first are simply geographic. Alaska is huge. It's the same size as the entire eastern seaboard west to Tennessee. And doctors are not located where the patients are. Nearly 70% of physicians are in the largest city of Anchorage, while patients live in rural communities scattered across the state. Rural communities like this one, the community of Teller, where I've traveled several times in the last few years for the study I'll be sharing with you about soon. There are very few roads in rural Alaska. That means travel requires travel by plane. This is my team waiting on an icy runway as we were about to travel between communities. And air travel in Alaska is really expensive. That means what we think of as a traditional patient-physician encounter has a lot of logistical barriers in rural Alaska. The state has overcome these barriers to care by implementing unique models of care across the state. The first is a network of village-based health clinics that are staffed by community health aides. These individuals are similar to community health workers that you would see in a low or middle income country setting. They receive very specific training to be the frontline medical providers for communities that otherwise would have no access to doctors or nurses. They're supported by a network of regional hubs and a single tertiary care hospital in Anchorage. For the past 20 years, telemedicine has been the backbone of healthcare in rural Alaska. In the early 2000s, a statewide network was developed that supports community health aides in rural village health clinics and connects them to audiologists in regional hubs, and then to the ENT surgeons who are based in Anchorage. My colleagues in Alaska have done really elegant validation studies to show that medical decision-making by telemedicine is equivalent, just as good as in-person care. And that has allowed this to become really standard of care for ear and hearing care across the state. What we did was take a step back and say, this telemedicine infrastructure works really well for clinical care, but it's never been applied for preventive measures such as school hearing screenings. What if we combine this technology with critical public health screening programs to make sure that every child with hearing loss in Alaska is identified and receives the care that they need and deserve? In 2016, we received funding from the Patient-Centered Outcomes Research Institute to launch an ambitious project that applied telemedicine to preventive care for the very first time. Our ultimate goal was to develop a better way to identify children with undiagnosed hearing loss, particularly those with infection-related hearing loss, and ensure that they receive the care that they need for this treatable health disparity. From the very start, this project was all about stakeholder engagement, stakeholder partnership, and community partnership. We had a Alaska stakeholder team that formulated the very core of the research questions that we were asking. This group of individuals was organized before the very first word was written for a grant. They worked hand in hand for the last 4 years with our scientific team that spans 3 institutions and our community partners, which included a tribal health organization and the Bering Strait School District, which is a very rural school district in a remote region of Alaska. Stakeholder and community engagement was central to every step in this project. I've already mentioned conceptualization and study design. This was also central to refining the trial protocol, ultimately contextualizing findings that we received, planning for future implementation, and planning for how to disseminate results back to the communities where this work was done. We used a mixed method study design, which is a very powerful technique for allowing for community engagement within hearing research. What this does is it allows for qualitative work to happen both before, during, and after a large quantitative study, such as a randomized trial, that facilitates community engagement and input in the work, community buy-in and what is happening, as well as interpretation and dissemination of results. The core of this study was a cluster randomized trial that was run in 15 communities in Northwest Alaska from 2017 to 2020. This study involved nearly 1,500 children from kindergarten through 12th grade. And because of strong community requests over and over during the first year in our study, we approached the funder and asked for additional funding to expand enrollment to preschool children as well. And in the second year of the trial, we enrolled over 90% of preschool children living in this region, because this is what the community wanted, was expanded access. Before the trial ever started, we began with focus groups and community events that allowed community members from all 15 communities to have input into the work that we were doing. We heard amazing stories about the impact of hearing loss and the importance of hearing and the Alaska Native subsistence culture. And our focus group participants had very specific requests and guidance for how the study was going to be run. For instance, we did not randomize screening protocols in this study because of community input, that community members felt it was important for all children to receive enhanced screening. We also chose cluster randomization because of community and stakeholder input. Community level events are really important in Alaska Native culture, and it meant that an individually randomized trial wasn't culturally appropriate, and it was important for all children in the community to receive the same referral pathway. The focus groups influenced how we designed the intervention, including how we communicated with parents, And our stakeholders were very influential in how we communicated about the study in general to the participating communities, including developing infographics like the one here. During and after the trial, we conducted 101 semi-structured interviews with stakeholders from all of these different stakeholder groups to understand experiences with the telemedicine referral intervention from every angle. Integrating community voice into dissemination of results was essential for this study. And we accomplished this through a cultural council that worked directly with the stakeholder and scientific teams to translate the preliminary results we were receiving into something that would really be meaningful to the communities that had participated in this work. We took these images and descriptions that the Cultural Council had helped to develop and brought them back to the communities to share preliminary results right at the source from where all this work began. And we worked directly with communities through focus groups to develop a community-guided dissemination plan for how to share this work more broadly and how to ultimately scale it up across the state of Alaska. Over and over again during this study, we heard powerful stories from community members about the impact of hearing loss on their lives. And we listened. Because of these stories, we brought a documentarian onto our team who developed audio and video and photographic media that allowed individual community members to tell the findings of this project and tell their stories in their own voice. These documentary pieces are almost ready to be released, and we are taking them back to the communities where they came from the very beginning before we share them with anyone else. The potential impact of this work is tremendous. Alaska Native communities have come together to develop a solution of screening and referral pathway that could potentially allow every child in rural Alaska who has hearing loss to be identified and connected to care. The concepts that have come from this study are applicable not just in rural Alaska, but in rural and remote communities across the world. How did this happen? This all came about because we engaged local communities. We listened and we empowered underserved and minority populations to be a part of the solution. This is how we as hearing loss researchers can partner together with communities to change the world. Thanks very much.
Great, thank you very much. So I am Carrie Nieman. I'm an otologist at Johns Hopkins, and I'm core faculty at the Cochlear Center for Hearing and Public Health, where I focus on understanding and addressing hearing care disparities among older adults. So we'll be continuing the theme that Dr. Emmett started in terms of thinking about that really big picture. And when we think about health equity, what we do on a day-to-day basis in the clinic truly matters. But I will argue and continue the conversation just like Dr. Emmett started in terms of what we do on the research side also matters. And if we're going to be thinking about hearing health equity at a community level and a population level, we really need to look at other disciplines beyond our own to think about what can we learn and what can we use to inspire and collaborate. So we'll be talking just really briefly about some of the concepts within social epidemiology that we can apply in thinking about hearing health equity. I have no industry-related financial disclosures. And as we talked, we are really focusing about that big picture level of a public health approach. And so we'll start a little bit about what social epidemiology is. What do we really mean by it? What do we know in kind of using the example of age-related hearing loss? And I think more importantly, what are some takeaways for all of us that we can apply some of these principles of social epidemiology as clinicians and as researchers? So we'll start with what do we mean? So we'll start with epidemiology. It's a word that many of us have heard time and time again, particularly now in the middle of a pandemic. But epidemiology is really at the foundation of public health. And epidemiology is the study of the distribution and determinants of health-related states or events at a population level. So when we think about the epidemiology of hearing and hearing health, we think about questions like, how common is hearing loss? How many people use hearing aids? What are the negative associations between hearing loss and an untreated hearing loss? Those are the types of questions that we can help try to answer through epidemiology. Something that is a defining part of epidemiology, which is similar to how we're trained as clinicians, is really the foundation of how we think about health and disease. Epidemiology traditionally has relied on what's called a biological paradigm, meaning that we think about disease as the product of individual behaviors working through biologic mechanisms. But the reality is, then we all know that disease, health, well-being has a lot more that goes into it beyond just individual behaviors. So that's what leads us to thinking about social epidemiology. And there's really been a push in the past 50, 75 years within public health and with epidemiology to try to capture some of those complex things beyond just the individual and the end product of health and disease. So social epidemiology is one discipline and one tool to help us think through that. So the study of the distribution and the social determinants of health-related states or events in a population is what social epidemiology is all about, because it's trying to think about beyond just that individual, the context within which the individual exists. So thinking about the social, the environmental, the geographic, the historical influences that all go into disease, health, well-being. And so something that's a really important shift within social epidemiology, and something that I think we also need to be thinking about, is really moving towards a little bit of a different paradigm where we're not just focused on an individual, their behaviors, and the biological mechanisms, but it's really thinking about disease as the product of both social, individual, as well as biological influences. And oftentimes, it's really the interaction of all these three things that then ends in terms of the disease process, health outcomes, things like that. And so, well, what do we mean by social determinants? Social determinants, as defined by the WHO, the World Health Organization, are the conditions in which people are born, grow, live, work, and age. These circumstances are shaped by the distribution of money, power, and resources at global, national, and local levels. And so when we think about social determinants of health, it can mean a lot of different things. And these are just a few of the social determinants of health. Things like economic stability, community and social context, as well as things like the healthcare system. And I would argue that within our field of hearing health, we are really not thinking enough about the social determinants of hearing health. And a lot of that does go back to the reality is when we look at health outcomes and the drivers that go into health outcomes, there's estimates that range up to 80% of what determines those outcomes are really these types of things beyond genetics and beyond clinical care, the things that we think we engage in every day, but all these other things that we're not always capturing within our studies. Another thing that I want us to think about that we can draw from social epidemiology is really some basic terminology. While we use these different words oftentimes interchangeably, they have a particular meaning within social epidemiology. So we can think about inequality and disparity as roughly the same thing. They both have to do with differences in outcomes, differences in care. Inequality is generally used internationally and implies differences based on socioeconomic position. Disparity is a term we often use in the US, and it implies differences by race, ethnicity. But those two are different than inequities. Inequities, yes, are differences in care and in outcomes, but there's also a value judgment in terms of the underlying mechanisms leading to those differences. So what does that mean? It means when we're thinking about inequality and disparities, we're talking about differences in care and in outcomes, but we're not saying anything about the underlying causes, or we may not know what the underlying mechanisms and causes are at work. But when we use the term inequity, that is something that we're saying in terms of avoidable differences that have attached to it some moral and ethical judgment in terms of underlying injustices playing in to those differences in care that we're seeing. So we'll talk now a little bit about what we know, trying to apply some of the social epidemiology to hearing health. And we're going to use age-related hearing loss as a quick example to go through some of these things and how we can see it in action in hearing health. Age-related hearing loss is common, right? We all know when we think about age-related hearing loss, we know that 2 out of 3 adults 70 years and older have a clinically significant hearing loss, and only around 15 to 20% of older adults actually use hearing aids. And when you look at nationally representative samples, and we look at things like hearing screening or hearing testing, often covered by insurance, we do not see differences by race, ethnicity. But when we start to look at other things like hearing aid use, we do start to see differences among older racial ethnic minority adults, where only around 10% of African American and Mexican American older adults with hearing loss actually use hearing aids. We can also look at other cohorts, not nationally representative, and we see similar things in terms of differences by race, ethnicity, and socioeconomic position. Another big part of social epidemiology in terms of trying to think about all these different complex factors that go into health outcomes and disease, one of those things is taking a life course approach. In the understanding that we think about outcomes that we believe that in part, at least, they're driven by cumulative advantage and disadvantage. And how do we capture that? And so this is one example of another cohort based in the United States that's been followed for 30 plus years, not nationally representative, but provides us a unique opportunity to think about over the life course what it may mean in terms of hearing healthcare behaviors and outcomes. And so we can see, at least here in this cohort, that cumulative socioeconomic status was significantly associated with hearing aid use in older adulthood. And even further, we see that childhood socioeconomic status, something that happened way back, was a big driver in terms of hearing aid use as an older adult. The other thing is the reality is that we are very limited in what we know about older racial ethnic minority adults, again, at this big kind of population level. In a recent systematic review that we completed looking at the past 30 years of clinical trials and studies that looked at bilateral sensorineural hearing loss, and less than 13% of studies even reported race ethnicity. And of those 125 studies or so that we looked at, only 5 included greater than 30% minority representation. So we really don't know a lot, again, from that big picture epidemiologic standpoint. So if we're thinking about social epidemiology and age-related hearing loss, we are thinking about kind of 2 main questions here. Well, so far we can say disparities seem to exist by race, ethnicity, and socioeconomic position, and among a lot of other factors that I'm not talking about here today. But the other thing that is part of social epidemiology where we haven't done as great a job at is thinking about mechanism, right? The whole point of doing all of these different studies is to try to understand what's going on, what are the drivers, so we can actually intervene and make a difference. And when we're talking about mechanisms underlying disparities and inequities, the mechanisms that we're talking about are things like social determinants of health, segregation, racism, discrimination, things that we have not done a great job of trying to capture in impact on hearing health. We know very little, and it really is a needed area of inquiry for many of us to be thinking about, both on the research and on the clinical side. So now I'll wrap up in terms of thinking about, well, what can we actually do here in terms of what are some of the lessons we can walk away with in terms of social epidemiology and this big picture view of hearing health equity? Well, as researchers, we need to be thinking beyond the biological paradigm of disease, right? What are ways that we can, in our studies, capture all of those things that we know go into outcomes and disease processes? If we're going to be selecting variables to include in our study, we need to be able to point to a theoretical framework of why we're including that variable so that we're doing it with intention. And we need more robust measures of social disadvantage. Yes, we all have usually used, education and income, but what are other ways to get at some of those things? And we want you to be thinking about how do you report self-identified race, ethnicity, and to do that more often so we can be able to capture more on terms of different populations. And we also need to consider who is not at the table, who's not being represented in our studies, and dedicated recruitment efforts to do that. And I think a big call to collaborate across disciplines is a major part of this. The other thing in terms of as clinicians and really for all of us that we need to be thinking about is understanding the biases that are really very much part of our training and our practice, to recognize them and to work to counteract them actively. We need to be considering the social determinants of health in our practice, how we capture them, how we're monitoring it. We have to appreciate the historical context within which we're practicing. We need to be working to expand representation in our field. And I hope that each of us are thinking, at least on a somewhat regular basis, of what can we be doing to advance hearing health equity. There's a lot of work to be done, but I think the good news for all of this and the theme that carries throughout, we do not have to do this alone, and we don't have to start from scratch. So hopefully you can take this charge and run with it. And then one last plug about the World Report on Hearing, recently out in March, and I think is another big tool and piece that we can use in trying to push towards advancing hearing health equity. Thank you.
I can't thank our speakers enough for what they have shared with us. With the few moments that we have remaining, we have just a few moments just to discuss some of these concepts and to circle back to these key principles for advancing health equity. Considering that first topic of being explicit, what groups are affected by inequity? Who needs resources, and where do we need clarity? So I would just open it up for my colleagues here of where else do we need to be explicit about naming disparities and describing, who is at risk and who is being missed. This will tie in a little bit to a question that was asked from one of our attendees about hearing aid participants. There was a specific question addressed to you, Dr. Hunter, about does your center assess this in hearing aid patients? So is it just cochlear implant, disparities that exist? Is it really a much bigger problem? I'll let you address that.
No, I think it's a good question. And I actually think Dr. Nieman summed it up very well in her last two slides. I mean, to speak to the specific question, I don't know. I have much better understanding of what patients are coming in from a cochlear implant perspective. And sometimes those patients, my patients who are from a hearing aid perspective, I'm aware of, but even those I'm not aware of. And so I think to Dr. Bush, your first comment here, what groups, I would argue, and I think Carrie or Dr. Nieman was alluding to it, like all groups are affected by it or can be affected by it, whether it's a cochlear implant patient or a hearing aid patient. That data is there. I'm sure it is. And I'm sure it's reflective of what I just reported, but that's why we look at it. I think it's a fair question to look into it, but right now I do not have the answer to that.
Anybody else want to chime in on just your thoughts of where else do we need to do work in describing who's being overlooked?
I think it's important to remember that inequities exist across the entire spectrum of the care pathway of hearing healthcare, and to really think about this from a public health and a population standpoint, because if we're only considering individuals who are coming into our clinics or coming in to see our audiologist for a hearing aid, for instance, or to see us about a CI, we're missing the vast majority of the population that even hasn't been touched at that point. And so thinking broadly about how we can use population-based screening, how we can partner with communities to increase awareness and increase access, using technology to increase access, particularly in rural areas where there are so few specialists. I think that's really the key, is to think broadly.
Well said. Regarding one of the next principles for advancing health equity about identifying and effectively addressing racism and racial implicit bias, how can we build culturally competent cochlear implant programs? What kinds of pieces do we need, do you think, to move our cochlear implant programs in diversity and promoting equity? Sheree, what do you think? You're in the trenches and you're making a difference on a daily basis, but how could our cochlear implant programs be more culturally sensitive and aware?
You know, I'm real big on representation, and I feel like just from my experience of being an African American woman, having a program that is diversified and healthcare professionals plays a big difference. I mean, Dr. Sami is Asian, I'm African American. I think people of color feel comfortable around seeing people of color. It just is what it is. And I think doing a lot of community outreach efforts, if you go out there to the communities and you bring awareness, people will start gravitating towards that because they see that you're caring, and that's going to make them care. And that's what I've been doing, is just like going out to communities. I've been going to churches. I go to any type of like urban leagues, anywhere I can pass out information, I'm there doing it. And I think that just doing that grassroots is what's needed.
I mean, to I think echo that. I mean, here we're all speaking the same language, English, right now. You could argue maybe Mandarin speakers or Korean speakers. I mean, it's the same entity, that they're going to want to go to a practitioner that speaks their same language, that can understand what they're dealing with. Right. And especially coming from my perspective, being a white male that speaks English, I mean, that's a significant barrier just right off the bat. And so, again, to echo Sheree's points, representation, not only on who you look like, but also what you can speak, I think speaks volumes. I mean, we have a large Spanish speaking population that, I mean, I wish I caught Dr. Rivas's previous discussion, but I think that's important. Language is very important.
Mm-hmm.
Sheree, there was a question from one of the attendees about just talking a little bit more about the support group, because that is some of that grassroots effort that really makes a difference. What does that support group look like, and how did that come together?
Well, so the support group is led by one of our patients who've just been passionate about spreading the news of cochlear implants and just providing that support. And over time, it just grew and grew and grew. Now, I will say it's mostly white individuals that attend, but Dr. Sami and Dr. Breen have been making a huge effort in making sure that when our patients are coming in to get a evaluation, and when they are open to getting surgery, both of them really are really adamant about those patients attending the support groups, because they have additional questions. And a lot of times, again, it goes back to that mistrust. I feel like a physician sometimes can only go so far, and they need to speak with the non-healthcare professionals, as I said before, that can just walk them through step by step, tell them their experiences, tell them the pros and cons, and just being around, like-minded people. That's basically what the support group is. And it's grown so big that every year we do picnics, and, it's kind of grown into like a little family.
That's a really important concept, that sense of family, a place of belonging and a place of welcoming and acceptance.
Yeah.
Our last key point for advancing health equity is about measuring and evaluating progress and reducing health disparities. And as Carrie and Susan have made it clear, that we don't know what we don't know, and we don't know what we're not measuring. Carrie, Susan, what do you think about, how can we move forward with, as a specialty, really trying to standardize and systematize how we assess disparities?
Yeah, I think it starts with just even seeing what do we have in our electronic health records, at least using what you have access to. I know there's a big push along many institutions to really try to capture those social determinants of health. So I think that is a big part, is just start someplace, just start, even, it may not be perfect, start. And I think the other thing is that there are many people beyond, ear and hearing care who are truly experts in this area that we can partner with, that we can understand, hey, what are the limitations if we use this variable, or what about this other variable? That I think, just starting someplace, and maybe your hypothesis is like, oh, maybe there aren't differences, but we need to ask those questions and look for partners to move forward.
I think there's also an important role for engaging with policymakers and working on the advocacy level, because for us to really make a dent in inequities, we need to be working at the population level. And that often involves working directly with state governments and really taking an inclusive approach that isn't so siloed to our individual medical centers, but is looking more at communities broadly. We also have a lot of room for growth in the metrics we use for evaluation. We've already talked about the importance of language. We don't have standardized cochlear implant outcomes measures that cover all the languages spoken in the United States. And that's just one country, much less the world. So there's a lot of room for improvement where we can ultimately change this process.
Well, we clearly have only just scratched the surface. I just can't thank you, my colleagues, enough for your participation in this panel. I have learned much and I'm inspired. Thank you, Dr. Jacob Hunter. Thank you, Ms. Sheree Sims, Dr. Susan Emmett, and Dr. Carrie Nieman. Thank you, attendees, for joining us today. And I encourage you, embrace these concepts and listen and learn about social justice and equity. We need to make better choices. We need to say better things, and we need to be better people. And it couldn't fit any better into our conference theme, which is that it takes a village. So let us do that together as a village. So thank you for your time and attendance today.